everyone for being here. This is the last talk of the year, this year, and we'll start again January first week. And I picked this topic because we all felt as a group, me, our fellows, and some of our faculty also, like we didn't have a great handle on this. And we had frequent patients more here and at the VA, frequently with this common issue. And the more and more I read, I didn't realize how common it is. And I just thought we'll do a sort of a brief overview. And hopefully, I learned a lot from this, and I hopefully can share it with you all. Those of you all, no relevant disclosures here. And those of you all who know me know that I always dedicate a talk to a group or people. This is to those scientists and researchers who were able to discover and define the androgen receptor and the aromatase, also known as the estrogen synthase, because thanks to these two discoveries, we have made so much advances so far in sex hormone dependent cancers such as prostate and breast cancer and so on, and also our understanding of gynecomastia and some of the rare diseases. So um, we'll be talking hormonal regulation of breast development and also outline pathogenesis, etiology, and differentials. And I'll summarize what I'm going to go through. First, the case and the definition and prevalence and breast development and physiologic gynecomastia. Aromatase, I call aromatase for this, in context to this talk, is the anti-hero or heroine, because today is Taylor Swift's birthday. Those Swifties, to them, and to her song, The Anti-Hero. So the androgen receptor here in the context to this talk is the tragic hero, unfortunately. And also gynecomastia of endocrine tumors and drugs. And of course, there are drugs and there are other drugs such as anabolic steroids, and also approach to evaluation management overall in terms of diagnostics, imaging, etc. And also what options are available for those it's not reversible, including surgical options. So hope to cover all of this in the short time we have. And the case, Kelly and I struggled to open my Epic. For some reason, it wouldn't download all afternoon. So I'm just going to summarize. Me and Dr. Kulkarni, our second year senior fellow, saw this patient just last week, and he was referred for microadenoma, a male in his 30s who is already has 3 biological children and is healthy otherwise, but has had long-standing gynecomastia since his 20s. The pituitary microadenoma was non-secretory and otherwise, the hormonal evaluation was all fine. We didn't have an estradiol level or a HCG, but this gynecomastia that he presented with was long-standing. And he did allude to the fact to Rohit that he did use a certain drug in his college days, just like everyone else in his group. And he was interested in bodybuilding. And that's a clue to what you may guess it is. So with that, I'll go on to the definition of gynecomastia. It's benign enlargement of male glandular breast volume. It's a common disorder that affects about 32 to 65% of men, depending on the age and applied diagnostic criteria. It can be a major source of physical and psychological discomfort. And also, it does raise fears of malignancy. And it also may be a sign of other endocrine or other systemic diseases. And certainly, we need to recognize that some of these patients or some of these definitions do have a physiologic context to it too, such as in infancy, which we'll talk a little bit about that, in puberty, very briefly, and then also as men age. And there's the entity of pseudogynecomastia, also termed lipomastia, which is caused by excess amount of breast adipose tissue. And there have been several studies since the 80s to more recently, showing that the prevalence of gynecomastia has increased over time, and some of it could be related to the higher BMI and higher accumulation of fat body mass. So breast ontogeny and development. So during okay, during fetal life, there is transfer of placental through the placenta hormones, maternal hormones, including estrogen. So the fetus does have, or the infant does have physiologic gynecomastia, and sometimes, rarely, even some milk production. It's called the vitreous milk, which resolves spontaneously. And also there is the sort of the precursors of estrogen being converted to estrogen sometimes early in fetal life. And so that also can promote gynecomastia in the infant. And in the epithelial cells, which are derived from the epidermis of this area, they program to become the areola and they proliferate into ducts, which then connect to the nipple and the skin surface. And of course, like I mentioned earlier, as the infant, with the blind ends of these ducts, they form alveolar structures. And with the decline in the fetal prolactin and placental estrogen and progesterone at birth, the infantile breast regresses until puberty. So the gynecomastia develops in situations where there is estrogen-androgen ratio abnormality. So relatively higher estrogen compared to the androgens. So there's a higher estrogen to androgen ratio, and any physiologic or pathologic situations can promote that. So, and androgen deficiency also by itself can cause gynecomastia. And of course, apart from these two, there are other reasons also that gynecomastia can develop. And many times, these patients can present with enlargement and sometimes with and without tenderness. So going back to the hormones that help with development of growth and differentiation of breast tissue. And the understanding we have now is thanks to the extensive research that has been done over time with promoters of breast tissue development and inhibitory factors such as testosterone. The promoters are estrogen through the estrogen receptor, and progesterone through the progesterone receptor, and prolactin through the prolactin receptor, and growth hormone, and also growth hormone with the circulating IGF-1. And interestingly, there is IGF-1 locally produced in the stroma also. So the estrogen receptor promotes the ductal growth, whereas the progesterone receptor promotes the alveolar differentiation. In the female, both work in congruence. In the male breast, because even though there is estrogen, since there's a lack of progesterone or a much lower amount of progesterone, there's not much alveolar differentiation. And that by itself sort of explains why the male breast development is arrested. Also, we know from several studies with hypophysectomized animals, mammals, that estrogen and progesterone by itself cannot help the breast development and milk production. You do need pituitary hormones and also other local factors. Pituitary hormones, growth hormone, and prolactin mostly. And growth hormone promotes development of the breast tissue. And also, we know from studies with acromegaly where patients sometimes develop gynecomastia that estrogen also promotes IGF-1's stimulation of breast tissue. And testosterone arrests or inhibits growth of breasts. However, excess amounts of testosterone in the presence of aromatase can get estrogenized, and that can again promote gynecomastia. And that's why many of our patients who are on very high doses of testosterone in contrary to what we expect, they do develop gynecomastia, and many times the levels are 2,000, very high supraphysiologic levels, and that sort of explains why that happens. So it is a very interesting sort of physiology of development of the breast, the type 1 ductules, type 2 ductules, and alveolar growth, and promotion to later for milk production after pregnancy and during parturition. So how prevalent is gynecomastia among men that I had mentioned earlier? Interestingly, 50 to 70% of all boys develop breast enlargement during puberty, and 30 to 65% of men can have palpable breast tissue. In hospitalized men, which I'll show you a study real soon, the proportion of gynecomastia is even higher, about 70%. If you think of all our heart failure, liver failure patients at Jewish hospital, many of them we do know this. So in autopsy studies, as high as 40 to 50% of men it was noted that they had gynecomastia. So adolescent or pubertal gynecomastia, a little bit, few words about that. So it's very uncommon to have pathological causes of gynecomastia. I don't know if any of our pediatric colleagues are in the talk, but they can chime in later. So less than 5%, but the less than 5% is a very interesting group of individuals. And the common causes are primary gonadal failure, which Klinefelter's, congenital anarchia, secondary gonadal failure, which is pituitary, hypothalamic pituitary axis, tumors, HCG producing tumors, which can also happen in children, and defects in androgen synthesis of functions such as 11 beta hydroxylase deficiency, and also androgen insensitivity syndrome, which is a very interesting area. We'll talk a little bit about that in a few minutes, and exposure to drugs such as estrogens, and of course, anabolic androgens, thanks to the TikTok videos we see recently. And very rare cause aromatase excess syndrome, which is again a very interesting syndrome, and we'll try to talk about that. So the prevalence I mentioned earlier has increased over time, and Denmark, or the Danish registry, is the most well-known registry for any male reproduction studies since the 90s, from the time of Dr. Nieschlag, who sort of worked a lot with Klinefelters. They have the best national registry to look at data in men. And this is a study from about 3-4 years ago. 7,000 men they looked at, and they looked them over a period of 20 years and looked at the diagnosis of gynecomastia. And they noted that, I'll show that graph in the next slide, is about 6.5 per 10,000 post-pubertal men between 16 and 20 had an annual incidence of gynecomastia, and 4.6 between the age of 60 to 80 years, with the 5 and 11 fold increase overall in these two age groups over a 20-year period. And this is sort of the summary of the study. This is the age group where there was a 5-fold increase over 20 years. And here there was an 11-fold increase in 20 years of gynecomastia. So we know this is a very important area of clinical issues. To go a little forward, using the same registry, more recently there was a study published. In fact, there's also I think, is it a journal club that they do in Endocrine Society? It comes on podcasts. They discuss this very interesting study from, again, from Denmark, where they looked at a total of 16,000 individuals and looked at those who had gynecomastia and those controls, age-matched controls, and looked at comorbid illnesses or associated incidental diseases by hazard ratio, and noted that whether they had idiopathic gynecomastia or overall with the diagnosis of gynecomastia, compared to their normal or healthy cohort, they did have a higher hazard ratio of comorbid illnesses, specifically endocrine and musculoskeletal diseases, which shows, sort of underscores the importance of evaluation of gynecomastia. Okay, enough said about the importance. So Going on to what is the histopathology or histology when you see a normal male breast tissue. You just have a duct lined by a single layer of epithelial cells and loose stroma. There's no inflammatory infiltrates or anything. This is the normal tissue. Well, move forward to a patient with gynecomastia. There's florid gynecomastia, proliferation of ductal epithelium, and periductal stromal tissue right here. And here we don't see that much, but in some of the other samples, we also see some adipose tissue mixed in. So this is a study from, I think, South Asia, looking at um, evaluation of the local factors, which we talked about earlier, which could be influencing gynecomastia. So it's very interesting because it's a surgical group of plastics from Department of Plastic Surgery. They looked at idiopathic gynecomastia patients, and they wanted to see the expression of receptors, expression of growth factors in this breast tissue. And there were about 29 individuals. And they do a grading, which we'll talk about later, because I'm familiar with Tanner's grading, but they do use a different grading in plastic surgery when they see patients with gynecomastia. So they used immunohistochemical techniques. These were patients who had idiopathic, who did not respond to conservative treatment, who underwent surgery, gland excision, and the tissue was then screened for estrogen receptors, progesterone receptors, aromatase, androgen receptors, IGF-1, IGF-2, HER2, and PTH-RP, EGFR, TGF-beta. And they found the prevalence of, and this is sort of a sample of the slides, like we showed earlier, extensive stroma and proliferation. And then there's also higher prevalence or positive expression of IGF-1 and IGF-2 seen in these patients. And also they looked at insulin resistance sort of calculations in these patients, looking at their fasting insulin and sugar. And these patients with the gynecomastia grade 3B had higher HOMA-IR, almost over 50% of them. And also they had 100% ER expression positive, followed by AR, androgen receptor, and aromatase and progesterone receptors, whereas HER2 and was negative or almost not there. EGFR, TGF-beta, PTH-RP was also not expressed. So it sort of gave an idea that these patients have a higher role of ER/PR factors, even though they're benign idiopathic gynecomastia. Just a brief sort of evaluation of exam of the breast. And honestly, none of us really do this extensive evaluation. Most of the time we walk in, I usually have to remind the fellows, make sure you do a chest exam, because many times you will be able to, and many times if their BMI is very high, it's hard to differentiate pseudo versus true gynecomastia. But ideal exam, as recommended by andrology or male reproductive experts, is to do it just like you do the female breast exam, and examine and make sure there's no firm nodules, which could be concerning for malignancy. And as you can see here, they do measurement of the areola, but and they say in imaging studies up to two centimeters or beyond is significant. However, I think we try our best to do a good exam, but this is something that is recommended. So what I do here. So classification, which I had mentioned earlier, we use the Tanner staging, especially in the girls and in the men sometimes, to just sort of describe. So the Tanner 3 is enlargement of entire breast, Tanner 4 is projection of the nipple and areola above the tissue, and Tanner 5 is normal adult breast in a female. And the plastic surgeons use a slightly different classification, which was developed from Mount Sinai by Simon's group, Dr. Simon and his group, Dr. Kahn and Simon. And they use a grade 1, which is small visible breast enlargement, no skin redundancy. 2A is enlargement without skin redundancy. 2B is moderate with skin redundancy, and grade 3 is marked breast enlargement with marked redundancy. So when you look at plastic surgery literature or surgical literature, this is how they describe the gynecomastia patient. So then moving on to one other symptom, that is galactorrhea, which while we talk about it a lot, it's hard to really see very many patients who present with this. I did have one patient who had it. And the reason you don't see much of it is the milk production requires a higher progesterone level, and the progesterone has to be then inhibited by rapidly increasing prolactin levels. In men, as such, there's not very high progesterone levels. So there's no rapid drop in progesterone by prolactin. So galactorrhea is not as common, although they present with gynecomastia. Very rarely do we see those in those patients. Plus, you need the breast acina development, which promotes galactorrhea. The male breast does not have enough of the tissue to have the galactorrhea. So those are the two reasons that lactogenesis does not happen in these folks. What are the differences when you do exam, when you see male versus, benign versus malignant breasts? So in malignant breast, usually it's unilateral, although you could see asymmetrical gynecomastia in pubertal groups, but typically in breast cancer, it is unilateral, and firm and hard nodules are present, and it's more peripheral outside the nipple area, unlike gynecomastia, which is around the nipple area, and it's extremely painless, which is always of a concern. And whereas gynecomastia, which we see in the office, many patients have mastodynia or painful. Even when they wear their t-shirt, sometimes they have a lot of sensitivity, and associated factors like pudet orange, dimpling, nipple retraction. We don't see that in physiologic or gynecomastia, and also lymphadenopathy may be present. So those are some of the. So coming to the etiology, which many of us are familiar with, and UpToDate has a very nice version of all the full list, but I'll just quickly go through it. The common, like I said, it's estrogen to androgen ratio alteration most often. So absolute excess of estrogen. Sorry if it's tiny print. Administration of exogenous estrogens, which we do provide to some of our patients, our trans men and women, and intentional therapeutic use, which is estrogens in prostate cancer, unintentional exposure, occupational, dietary exposure, which is phytoestrogens, and we all know soy products and more EDC, which is environmental agents, which can cause the same impact. Percutaneous absorption like anti-balding cream from partners' estrogen cream that they're using topically, and increased endogenous estrogen production, which would be from Leydig cell tumors, stimulation of normal Leydig by HCG many times, and from adrenals, feminizing adrenocortical tumor. Anytime you see an adrenal nodule patient, independent, of course, you look at the imaging phenotype, but when you see a male with gynecomastia, recent onset, and adrenal tumor, we have to think ACC. I've had at least 2 patients. It feminizes, and then in the women, it virilizes them. So it's very important to remember that. Then increased aromatization of androgens to estrogen, aromatase excess syndrome, which I hope to spend a couple of minutes on. Drugs such as androgens, alcohol, of course, a big issue, alcoholic cirrhosis of the liver, aging, which we talked about a little bit, obesity, hyperthyroidism. There's several case reports, and we ourselves have seen over the years of patients presenting nothing, young men and sometimes middle-aged men also presenting with nothing but just mastodynia and gynecomastia. And then lo and behold, they have a nodule, thyroid hyperthyroid thing. Then HCG secreting tumors is the other group of thing. Then absolute deficiency of androgens, hypogonadism. We talked about most often ones on top. And then testicular radiation, mumps, orchitis, leprosy, and drugs such as ketoconazole, spironolactone, metronidazole, inherited defects of androgen biosynthesis, and also some other interesting areas such as refeeding gynecomastia, renal failure and dialysis, and androgen receptor defects, either absent or defective, or expansion of CAG repeats, which I'll go over Kennedy's disease briefly. Just to summarize sort of the whole spectrum of gynecomastia. So you either have a steroid producing organ, the testes, and sometimes the adrenals. And then there's HCG tumors, or there's conversion of the testosterone to estradiol through aromatase, either pathologic or physiologic. When there's increased adipose tissue or with aging, there is increased aromatase activity. And then also drugs which can displace estradiol and estrone displaced by some of the drugs, which we'll talk about a few of them. Then another important area is environmental estrogens, which I had just mentioned, an estrogen receptor. So this sort of summarizes a little bit of what happens with and another important factor, which Dr. Winters alludes to it a lot. He's in Vietnam today, or Cambodia, so he wasn't able to join. He already sent me an email. Is that when you have higher SHBG with aging, and then you bind all the available testosterone, and there's not enough free testosterone available. And then what happens is the estrogen stimulates and causes gynecomastia, and that happens sometimes. So any states of high SHBG can stimulate gynecomastia, and that's a very interesting mechanism to remember. So coming on to the next sort of the most important factor, and that is aromatase. Like I mentioned, the anti-hero, and this interesting sort of when we talk about the human aromatase, we also have to think about the animal models of it. And this is a certain kind of a chicken. It's called the Seabright Bantam chicken. And this study was done in the 1980s. These chicken have aromatase defect. So this is your classic male chicken with the plumage, very, very typical generous feathers. And this is the female normal chicken. This is the henny feathering chicken, which is a certain kind where there's aromatase mutation in these chickens. So while they are not, they are fertile and everything else is fine, but their plumage, which is the feathers, are more like a female phenotype, almost similar to the female here. So, which is something, the aromatase sort of impact of aromatase does that. So, and this is the structure of the aromatase gene, which is determined by crystallization of the aromatase from its substrate, which is androstenedione. And there's a lot of work being done. And as we know, it is aromatase inhibitors, or what we use for breast cancer secondary prevention. So it is estrogen synthase, and it plays a very important role in men. And it causes, it converts almost 15% and less than 5% of estrogen and estrone in the adult testes, and also through extraglandular sites to estrogen, such as in the adrenal gland. And also, let's see, okay, here it is. So this is sort of the work or impact of aromatase on testosterone conversion. It happens in the extraglandular tissues, where it converts androstenedione to estrone and testosterone to estradiol. And also in circulation or steroid secreting tissues, such as the Leydig cells, and in the adrenal gland, it converts testosterone to estradiol. So, and when there is any condition where there's aromatase excess, either physiologic or pathologic, that causes gynecomastia. Increased precursors can happen in puberty, which is testosterone excess amount, so it gets converted. Adrenal tumors that produce excess of any precursors such as androstenedione that converted to estrone and estradiol. 17-oxosteroid reductase deficiency, liver disease, and thyrotoxicosis. In these areas, you have increased precursors and increased aromatase activity, which I mentioned already, obesity and aging, and the familial aromatase excess syndrome and neoplasms, including Sertoli cell tumors that could be associated with Carney complex Peutz-Jeghers syndrome, trophoblastic tumors, and also feminizing adrenocortical neoplasms, hepatocellular cancer, and through an unknown mechanism in Klinefelter, idiopathic gynecomastia, thyrotoxicosis, and of course, spironolactone. And just wanted to spend a few minutes on this very interesting syndrome. It's called the aromatase excess syndrome. We probably don't see very many, and I'm sure in pediatrics, it's rare, but certainly seen in pediatric, and it's a familial gynecomastia. So, and there's been several case reports in different countries looking at it, where the dad has it, the child has it, they're otherwise physiologically fertility, everything is fine, but they do have gynecomastia, and it is excess aromatase in these patients. So it was first identified in 1985, and I couldn't find a phenotype picture for this, so I could not add it. 13 years later, Dr. Stratakis coined the name AEXS, which is aromatase excess syndrome. And in affected boys, they saw aberrant expression of the mRNA from CYP19A1, and which encodes aromatase. And it's found in many tissues, in adipose tissue, and converts, as I mentioned earlier, androgens to estrogen products. And they discovered the genetic basis of AEXS after that. And it was like I mentioned earlier, CYP19A1 a promoter defect, and there's several sort of variations of this. And these men, boys with this syndrome, present with prepubertal gynecomastia at the age of adrenarche, quite young, and when DHEA levels are very high. And later during puberty, there's excess of estrogen causing inhibition of normal testicular growth, and there's no virilization, and because the gonadotropins are suppressed by the excess estrogens. And there's also acceleration of height velocity when they are very young, just like your CAH patients, tall children and short adults. And there's a height velocity bone maturation happening very quickly. So for instance, a 5-year-old child with this syndrome can have a 13-year-old bone age, and then they're compromised by very short adult height and early epiphyseal closure and premature growth arrest. And it shows their analysis shows estrogen, estradiol, and both are affected, higher levels of that. And in the women, the females with the same phenotype, they have early menarche, macromastia, accelerated bone maturation, and adult short stature. So it is a very interesting syndrome, and there is 1 or 2 studies looking at anastrozole early on in these children, trying to intervene the excess aromatase action to minimize, so at least let them get to the adult height. There's been some studies, but in the interest of time, I will not add that. So next, John, I don't know if this is actually a ESAP question, but I felt like it would be a good one to sort of use here. He's a 21-year-old male with gynecomastia. He reported puberty around age 14 years, a little bit later than his peers. He's otherwise healthy, and there's breast enlargement noted at puberty, progressed for 1 year and then stabilized. There's no family history such as the earlier syndrome we spoke about. And normal body proportions, and normal vital signs. The weight is 72 pounds, BMI is 24. Upper segment is upper to lower body segment is 1.1, and the arm span is 67 inches. And also, let's see, there's no visual field defects. And Tanner stage 3 bilaterally, sparse body hair, sparse pubic hair, and phallus size is reduced. Testicular volume is 15 cc. And results, testosterone is 1200. Repeated again with a different assay, again 1300 nanograms. SHBG, this is what we use, nanomoles, 60, which is sort of high. Estradiol is 47, slightly on the higher side. LH 15.8, FSH 14.4. So any idea, guys? Okay, I'll give the choices here. Genetic testing for pathogenic variants in the androgen receptor gene, estradiol gene, DHEAS, free testosterone, and pituitary MRI. So I sort of will hold it right here while you guys are thinking, and I'll go on to the next discussion, and that is the androgen receptor. You may have guessed that was a insensitivity, androgen insensitivity syndrome. But we talked briefly about the androgen receptor, which is again a very, very interesting player in this talk. So the androgen receptor, as you can see, the functional domain, it's got a DNA binding domain. It's called DBD. And the ligand binding domain where it binds to testosterone, and actually the active form, which is dihydrotestosterone, DHT. And this is sort of the protein, very interesting protein it is. And the androgen receptor mutation is the resistance to androgen action when the mutation happens is referred to as androgen insensitivity syndrome. It occurs in about 1 in 20,000 to 1 in 100,000 male births. And there's a wide spectrum of it. It's, could be very mild to all the way to female phenotype. So the AR gene is coded as a single copy gene in the X chromosome. So usually it's X-linked recessive disease. And they have a 46XY karyotype with a very hemizygous AR variant. And there's a lot of de novo variants also, like I mentioned earlier, and I'll show you some of the little different spectrums of this, and the receptor codes for about 900 plus amino acids. So anything can go wrong there. And when to suspect somebody with androgen receptor mutation, such as the case that I just presented, very high T levels, very high gonadotropins, but in spite of the high T levels, no virilization present. So it's should be considered if the men and women of any age, including newborn who have atypical genitalia. So mostly with our pediatric colleagues, usually they get diagnosed and it's the disorders of sexual development or DSD. And females with inguinal hernia or labial masses, as much as 1 to 2% can have CAIS, which is complete androgen insensitivity syndrome. And newborn with female phenotype, which the karyotype shows 46XY, and females with primary amenorrhea, normal pubertal development, but diminished pubic hair. And adolescent girls who become virilized and develop clitoromegaly, and also adolescent boys who do not undergo male puberty or have persistent gynecomastia, such as the patient we just saw, and adult men with undervirilization or infertility associated with azoospermia or severe oligospermia. So it depends on the residual transcriptional activity of the androgen receptor gene. So if the phenotype is a complete, which is CAIS, complete androgen insensitivity syndrome, it will be, we had one such patient. I don't know if the patient is still in the practice. They would look with female phenotype, but a 46XY karyotype, because testosterone is completely aromatized to estrogen. And they may have male range testosterone also. So there's absent uterus in these individuals, and they have primary amenorrhea and a blind vaginal pouch on exam. So the partial PAIS, partial androgen insensitivity syndrome, can have undervirilization, but they may have a normal phenotype, and they can have hypospadias, micropenis, or bifid scrotum. And when the androgen receptor is mildly impaired, which is mild androgen insensitivity syndrome, they can develop gynecomastia, infertility, reduced facial hair, and pubic hair. So they do respond to estrogen, these patients. So, and estrogen is primarily required for closing epiphysis. Body proportions are usually normal. So they may not be unicoidal proportions that you see that with Kalman syndrome. And they also, because Kalmans, they lack both testosterone and estrogen. So that is sort of the spectrum of these patients. And they could the complete AIS, like I mentioned earlier, complete female external genitalia, short vagina, and they have abdominal and inguinal gonads. They're feminized completely, and secondary sexual development is absent. Spermatogenesis obviously is absent, and the mutation is located throughout the AR gene everywhere. And post-pubertal gonadectomy is favored. The partial AIS is clitoromegaly, narrow vagina, variable fusion of the minora and inguinal testes or inguinal gonads. There is some breast development and slight virilization. And there's mostly DNA or DBA sites, DBD sites, DNA binding sites, and hormone binding domain of the androgen receptor. And gonadectomy prepubertal is favored in these folks. Then partial AIS, male, because the first two are female. Partial AIS, they have hypospadias, scrotal bifidum, and the testes is usually normal location. There's persistent gynecomastia, such as the individual we just talked about. And they have severely impaired spermatogenesis, and DNA binding and hormone binding domain is affected. There's no gonadectomy recommended because it is in the scrotum. And then the minimal AAS is unambiguously male patient, scrotal testes, gynecomastia, but virilized, severely impaired spermatogenesis. And it's located throughout the AR gene, and we'll talk about Kennedy disease. There's no gonadectomy, but surveillance is recommended. So the answer for our case 2 is genetic testing for pathogenic variants of androgenic receptor. Just a few words about Kennedy's disease, because it's a very interesting spinobulbar atrophy or spinobulbar muscular atrophy, SBMA, along with hypogonadism. And there is the mutation is in that androgen receptor. It's X-linked disorder. So the mom is the carrier for these patients, and there's motor neuron loss. So it's similar to ALS sort of presentation, except their lifespan, there is no change. Like, no, they do live up to, it's not affected, and there's no premature mortality or anything, which is good news. But motor neuron loss in the anterior horn of the spinal cord and the bulbar region of the spine. And they develop progressive, usually develops in their 30s. So they are healthy young children and adults most of the time. And they develop progressive lower extremity, more of lower extremity than upper extremity weakness, then facial muscles, fasciculation, tremors. So any hypogonad patients who complains of dysphagia, dysarthria, or frequent falls, we have to keep this in mind, especially when they present with gynecomastia and everything. They do develop aspiration, pneumonia, and respiratory failure. And they all of them 100% have gynecomastia, and some of them have testes which are smaller, oligospermia, and a clinical androgen deficiency. I think we have one patient in our practice, which I saw a few years ago, but they have not followed up since. So, and they also have a very classic appearing sort of deep fissures in the tongue area. So that's also a very classic presentation. And it's one of 9 neurological disorders, which it's called polyglutamine diseases, and it's similar to Huntington's disease. And It is the etiology here is very long. The androgen receptor has the cytosine, adenosine, guanine repeats of the amino acids. And in these patients, the longer the length of this, the higher the incidence of this mutation. So you want to have a smaller length, and these folks have, I think 35 is the maximum, and they have much higher than that. And that is where the problem is in these patients. And there's misfolding, and that causes sort of binding and translocation to the nucleus. And it also affects the bulbospinal neurons, and it's seen here. There's a transcription and translation of the AR target genes, and this is your androgen receptor and dihydrotestosterone. In a normal individual, there is an interaction with the androgen receptor, DNA interaction, and there's downstream transcription and target genes. Whereas there's here loss of function and toxic gain of function with this misfolding. So it's bad enough that it's loss of function. There's also pathologic gain of other function. So it forms nuclear inclusions, and it affects the motor neuron, causing clinically weakness, hypospermatogenesis, gynecomastia, increased SHBG levels, androgen insensitivity, increased LH, and increased testosterone levels. However, clinically, they are underrealized. So it's a very important disease, rare, but very important. And like I mentioned earlier, it does affect the motor neuron and the skeletal muscle. So there's been a lot of key insights into the androgen receptor based on the androgen receptor knockout. This is the wild, and this is the knockout, prepubertal, postpubertal. The impact of androgen receptor mutation can be seen in the bone, which we all know about. The reduced size, thickness, volume, increased bone turnover. In the brain, absence of male sexual aggressive behavior, cardiovascular system, reduced heart size, impaired contraction, exacerbation of ANG2, cardiac fibrosis, glucose metabolism. They are more insulin resistant, which is sort of could be guessed. Increased subcutaneous and visceral fat mass, decreased voluntary activity, late onset obesity, hyperinsulinemia, and high levels of leptin and adiponectin. Immune hematopoietic system, they do have reduced neutrophil count, increased self-renewal of bone marrow mesenchymal stem cells, and accelerated wound healing. Muscle, there's decreased skeletal muscle, perineal mass, decreased strength. And prostate, it is androgen receptor dependent organ, and there's no prostate development. So this is a knockout model sort of thing. So other signs and symptoms related to tumors producing or estrogen producing tumors or malignancies causing gynecomastia, Leydig or Sertoli cell tumors, there's testicular pain, enlargement, decreased libido, and many times the contralateral testes may have some atrophy and the signs of feminization. Germ cell tumors, they have also testicular pain and also other symptoms of metastasis many times, back pain, hemoptysis. I think we had one patient where that testicular mass is noted. Then adrenocortical tumors, weight loss, decreased libido, Cushing's syndrome like symptoms or mineralocorticoid excess. And certainly everyone here is familiar with Cushing's presentation. Ectopic HCG secreting, there's weight loss. And if it's a lung cancer with ectopic HCG, certainly symptoms related to that. And hepatocellular, gastric, or renal cell cancer with ectopic HCG can have similar symptoms. So, and hypogonadism, everyone is familiar with hyperthyroidism, liver disease, androgen insensitivity we just spoke about. I'm going to skip this part since we just spoke about the tumors. We'll go to the drugs briefly. And there are drugs that cause by known or proposed clear mechanisms, estrogen vaginal cream, which is through estrogen receptor binding, digitalis, clomiphene, marijuana, weak evidence, but we do know that sometimes we have seen patients with that. Stimulate estrogen synthesis, gonadotropins, growth hormone. Then supply aromatizable estrogen precursor, which is exogenous androgen. Testicular damage directly causing hypogonadism and gynecomastia, busulfan, vincristine, ethanol, TKIs. Then blocking testosterone synthesis, ketoconazole, spironolactone, etomidate. Blocking androgen action, flutamide, bicalutamide, which is your prostate cancer drug, and cimetidine. I forgot to mention, actually, the first slide I had was a 1979 presentation. Dr. Winters sent the link, so I thought I'll put it on there, about a discussion about cimetidine being anti-androgen, and also displacing estrogen from SHBG, which is spironolactone and ethanol. And those uncertain mechanisms, there's extensive list of them: amiodarone of interest, nitrates, neuroleptics, Valium, phenytoin, tricyclics, and again, a bigger list, including HIV meds, amphetamines, methadone, heroin, and statin. There's weak evidence, but certainly there's case reports. DPP-4, methotrexate, Sulindac, and domperidone, and those agents. Let's not forget anabolic steroid androgens. We still see a lot of it, especially during the pandemic, and now with all these different male clinics and quest for sculpted appearance. There is, this is the World Anti-Doping Agency is list of sort of prevalence of using anabolic androgens, and over 75% of AAS users are actually not athletes. And among the athletes, there's a 44 to 70% use, except only less than 1% get caught. So, and then these are some of their symptoms: reduced testes volume, increased cholesterol, blood pressure, ED, acne, and gynecomastia. So we need to sort of catch them when we can, or at least diagnose them. Many times they don't realize there's a problem. So there's reduced LH-FSH and increased T and estradiol, and reduced SHBG also is noted compared to the controls. So coming to the algorithm of investigation of gynecomastia, which we sort of went through it already, but first thing to make sure is there's no tumor. So checking a HCG, testicular ultrasound, and a quest for finding the tumor, CT abdomen, thorax, testicular germ cell tumor diagnosis, or extragonadal, adrenal, and HCG, trophoblastic neoplasm. So it is a pretty extensive differential diagnosis. If HCG is normal, if their testosterone is low, and then you go to the gonadotropins, and then you sort of establish the diagnosis. If the T levels are high, LH is high, we worry about androgen resistance and look for the androgen insensitivity syndrome, which we talked about. If the T is normal, but the estradiol is elevated, and then again, testicular ultrasound to make sure there's no Leydig or Sertoli cell tumors, or there's no adrenal tumors or extraglandular aromatase activity. And if normal E2, normal T, then it's idiopathic gynecomastia. There is the problem, because at this point, we're not sure what to do, because we can reassure these patients to hope that it'll regress. One thing to remember is if it's not a reversible cause, such as medications or any of the other diagnoses, then many times earlier it's easier to reverse, but the longer there's gynecomastia and they develop fibrosis, reversal is very hard after years and years of it. So usually 3 to 6 months is the time frame for reversal, if we sort of think. And then if patient have very painful gynecomastia, very uncomfortable, affects their daily life, then we start discussing reasons. Now, this is idiopathic. This is ruling out all those other exhaustive differentials. So, and certainly many of them, it is pain, tenderness, psychological embarrassment. So certainly something to discuss about. I'll first mention surgery. That's not the first step to go to, and certainly not in prepubertal, because you want to wait till they go through puberty, because most of them will spontaneously regress. And if surgery is decided well after puberty is completed, and the options are subcutaneous mastectomy, ultrasound guided liposuction, suction assisted lipectomy, certainly with surgeons who are very familiar with this, because we want to make sure that the surgery goes well and the results are good, because it does affect the patient's confidence and other psychological impact. So and minimally invasive surgery is available now. Medical treatment, many of these are not FDA approved drugs, but whatever studies we have, I'll discuss. SERMs are one option, clomiphene, tamoxifen, raloxifene. Androgens such as danazol, by directly increasing the concentration and rebalancing. Danazol studies are seen in children, young adults, but not so much in older adults. Aromatase inhibitors, which we use a lot for the women, and anastrozole, testosterone. So this is a summary based on the different studies, and for in the interest of time, I'll sort of skip through it. But in summary, the best one, which had the best outcome with minimal sort of impact or side effects, is tamoxifen, 10 milligrams BID or 20 once a day. Many of them do have a very good regression. And this same drug can also be used for prostate cancer treatment, because many patients who undergo treatment for prostate cancer, because they're feminizing, do develop very, very disturbing, painful, disfiguring gynecomastia. And there have been extensive studies looking at use of tamoxifen, actually much lower dose and less frequently in a week, with very good outcomes. And of course, more recently, the newer agents, anti-androgens used for prostate cancer, such as the abiraterone and enzalutamide, all that have minimal gynecomastia. So it's less of a problem these days. So our patient that I presented early on, Rohit did go back and look, because he mentioned what drug he was using. It's called SPA, and it was this is the FDA's list has this. It's an anabolic androgen, as I mentioned earlier. It's called myogenics, and it's been pulled off the gray markets now. And this was a release in 2012. And so to summarize, we went over a couple of cases, definition, prevalence, went over breast development and physiologic gynecomastia, infant aging, and young pubertal, and a few minutes of aromatase and androgen receptor. Very exciting and very interesting two agents which have a major role in this disease. And then endocrine tumors, and some details about drugs, and also approach to evaluation and management, mostly reassurance and exhaustive evaluation of any etiology would be very helpful. This is a very nice summary slide with all, it is in up to date, so I just copied it. It pretty much has a lot of the discussions that we just talked about. And thank you all for your time. And this is the event code. And happy holidays to everybody. And I'm happy to take any questions.
How large does the increase have to be considered clinical gynecomastia?
So how but the
1 centimeter.
yeah, so the CT imaging, some of the andrologists talk about 2 centimeters on imaging. By exam, many times we use the grading, that the Simon's classification, or we use the Tanner stage. Many times it's quite obvious in a lean individual. In some other individuals with higher BMI, sometimes just the high BMI and adipose tissue looks like gynecomastia, but it's not. It's a very different sort of breast tissue, areola, the mound development, which looks different from a general lipomastia. So. Mm-hmm.
If it's so common
Mm-hmm.
in puberty
Mhm.
development,
Mm-hmm.
then I'd imagine it might just be called normal.
Yes, they regress. So the question is, if it's common, Dr. Levinson mentions, if it's so common in puberty, does majority of them regress given enough time?
And also, if it's very small,
Mhm.
I mean, where did they get the numbers from, I'm wondering? Because
I mean, this is based on prevalence studies, national registries, and other studies. I think it's from different areas, from reviews and all that, and many of them are meta-analysis also.
I just wonder if it's not kind of overestimated.
Overestimated. Well, it is expected that when you have a surge of the testosterone, especially if the BMI is higher, in the interest of time, I didn't add those slides looking at BMI and prevalence of gynecomastia, and BMI and aromatase activity and conversion of testosterone to estrogen. So higher the BMI, higher the risk of this, and many times it's physiologic, and as the puberty is completed, I think it gets better. I mean, I know our pediatric colleagues may be able to tell me more about it, but
Thank you.
thank you. Any other questions? I see some questions here. Let's talk Amod Kulkarni. Gynecomastia do not need, at least some of the drugs causing gynecomastia over the counter don't need prescriptions. Omeprazole, is it not a concern? I do not think that they come with a strong warning. You're right. 65% of soy products, which is phytoestrogen by Chinese population, is gynecomastia common in this population? I haven't looked at racial differences, but it is possible. But you're right about the phytoestrogens, increased gynecomastia prevalence, and of course, alcoholic beverages. It's due to ethanol, actually, not phytoestrogens in alcohol. And due to endocrine disruptors from food and medicine reversible. If long, how long do they have to be? I know in endocrine society, the EDC causing gynecomastia, infertility, is being talked about the last 15 to 20 years a lot, but I don't know if reversing is possible and how many months or years it takes. I'm not sure about that, but if I find out, I can let you know. Are there an EDC in food that can reverse gynecomastia? I'm not sure. I'm not sure about that. And this is from Dr. Kotwal. Thanks for the great review. Is it appropriate to say major causes in aging men are high BMI and low testosterone or excess estrogen? Does gynecomastia often transition to male breast cancer? Does treatment to reduce testosterone with drugs like Lupron give prostate cancer? Increase how to balance prostate cancer with prevention of gynecomastia? Well, it's multiple questions in one. Let me just address the first question. High BMI, low testosterone. Yes, aging causes fat body mass, lean body mass changes. So there's certainly that factor. Then aging SHBG levels go up. So there's more binding of the testosterone. So there's less free testosterone available. So there's more estrogen activity. And then the third issue, yes, there's a physiologic lowering of testosterone also. So definitely, yes. Now, does gynecomastia transition to breast cancer? No, I have not heard that. I don't know if anyone else here has. So far as I know, they do not transition to breast cancer. And also treatment to reduce T levels with drugs like Lupron. There's been some studies looking at that. And like I said, tamoxifen is one of the drugs being used. Some people use radiotherapy, but it's not as common. It's mostly tamoxifen. And let's see. I mean, duration of exposure, certain foods that develop gynecomastia. I know the longer you're exposed, I think the higher the risk. And certainly there's definitely a lot of environmental estrogens. And we have seen that they do impact fertility also in young men. So we have to do a lot of studies in that area, the environmental estrogens. So yeah, thank you for all the questions. Well, if that's all, Thank you all and have a wonderful holiday and season's greetings. Okay, take care, everyone, and thank you for attending. See you all in New Year.